Okay, having hit the magic, past the magic marker of 50, I think it's a great time to get started. So welcome everyone today to our webinar on Medicaid managed care contract provisions for pediatric to adult transitional care, where we're going to review some suggested options and wonderful state examples from Florida and Texas. I want to recall that today is Friday the 13th. It turns out that in this year 2020, we have had two Friday the 13th. The first one was on March when the COVID epidemic was announced, and today. So it has been quite a year, and it's nowhere near done, but we're very excited to have you with us today. We plan on sharing several recommendations and impressive state examples for including transitional care into Medicaid managed care contracts. From my experience from years of working on Medicaid issues, I've come to realize the substantial importance that Medicaid managed care contracts have. They establish guidance, best practices, standards, and the way forward. They are critically important to the system of services for children, youth, and adults served by the program. I think today we will learn more about options for taking advantage of these important Medicaid contracts to guide improvements in transitional care. I want to thank our funders of this work, the Federal Maternal and Child Health Bureau and the Lucille Packard Foundation for Children's Health. I would also like to acknowledge our colleagues at the National Academy for State Health Policy who have offered thoughtful direction on our work. And I would also like to encourage attendees to check out the new report by NASHB and the Catalyst Center that examines the role of state Medicaid and Title V program definitions of children with special needs and NASHB's new care coordination standards. So let me begin by introducing our speakers today. Annie Schmidt is a research and policy analyst at the National Alliance. Annie co-authored our Medicaid managed care report and is the key staff person working on value-based payment and coding and reimbursement. She is also co-chair of Gut Transition's National Family Advisory Group, which just published a new toolkit on transition with a corresponding webinar done in conjunction with Family Voices. I'm also pleased to welcome Johnny Hollis, who is the Director of Clinical Operations for Florida's Office of Children's Medical Services, Managed Care Plan, and Specialty Programs. Johnny Hollis oversees the administration of the state's Title V Maternal and Child Health Block Grant for children and youth with special needs. Ms. Hollis works closely with system stakeholders, including WellCare, in the coordination and provision of quality services for children and youth with special needs. Ms. Hollis uses an interdisciplinary team approach in the implementation of evidence-based services and programs for regional and state levels. Tanya Hillary is the Vice President for Children's Medical Service Operations for WellCare in Florida. In that capacity, Tanya oversees the operation of the Florida Department of Health Specialty Managed Care Plan, called the Children's Medical Services Health Plan. This plan serves Medicaid and CHIP-insured children and youth with special need. Tanya works closely with the department and system stakeholders, including families of children with special needs, in the development of a quality-based youth transition program. Elizabeth Tucker is the Executive Director of Every Child, with more than 3 decades of experience in advocacy, policy, and program development to support children and adults with significant disabilities to live fully inclusive lives in their homes and communities. Elizabeth has a deep understanding of Texas Medicaid and works closely with the Texas Health and Human Services Commission and the Texas Department of Family and Protective Services to develop public policy that improves the lives of individuals, children, and family. Elizabeth participates in a variety of state-level advisory groups, including the Policy Council for Children and Families, and is co-chair of the Star Kids Medicaid Managed Care Advisory Committee. Star Kids Medicaid Managed Care was implemented in Texas in late 2016 and serves approximately 62,000 children and young adults under the age of 21 who have SSI or who are receiving services from a home and community-based waiver. Thank you all the panelists for joining us today. I'll turn it over to Annie, and then we'll follow with our Florida colleagues, and then our Texas colleague, and then question and answers, which you can please insert all along the way in the chat box. Thank you.
Great, thank you, Peggy. Okay, so here is just our funding information that Peggy stated for you. And here are our presentation objectives. So we're going to start by offering some background information about healthcare transition, and then we will discuss some options for incorporating pediatric to adult healthcare transition language into Medicaid managed care contracts. And then we will hear from how 2 states have incorporated this language into their contracts. So for some background information, in 2018, the American Academy of Pediatrics, American Academy of Family Physicians, and American College of Physicians published a clinical report on healthcare transition that recommends all youth with and without special healthcare needs receive a structured transition process called the 6 core elements of healthcare transition. And this facilitates the transition from pediatric to adult healthcare. And this process should begin early in adolescence and continue into young adulthood. It facilitates transition planning, transfer of care, and integration into adult care. And research consistently shows that when a structured transition process is in place, youth are more likely to experience improvements in health outcomes, such as adherence to care and self-care skills, experience of care, such as patient satisfaction, and utilization of care, such as increased adult clinic attendance and reduced hospitalizations. So this figure is based on the 6 core elements, and it summarizes or it lists out a set of services that should be offered on the pediatric side during the transfer of care, and then on the adult side. So on the left are some transition planning services that should be offered on the pediatric side, starting between the ages of 12 and 13. So just some examples are to develop a policy to share with the youth and young adult and family that shares the practices approach to transition, including the age of transfer. Another service is conducting the transition readiness skill assessment and preparing and updating the medical summary and emergency care plan. And then in the middle are a set of transition services to be offered during the transfer of care that typically occurs between the ages of 18 and 22. So this includes exchange of a transfer package, which includes items such as the transition readiness assessment and medical summary. So that package can be sent from the pediatric clinician to the adult clinician. This also includes communication between the pediatric and adult clinicians and clarification of their roles prior to the initial visit with the adult clinician. And then on the right are transition services that should be provided on the adult side. So these are services to integrate the new young adult into the practice. So just a few examples are developing a transition policy for accepting the young adults, identifying adult clinicians in the practice to care for new young adults, and preparing a set of frequently asked questions and orientation information for young adults. So this figure is included in the report that is cited at the bottom of this page, and I'll be referring to this report throughout the rest of the presentation. Close to half of youth with special health care needs between the ages of 12 and 17 are publicly insured. And despite professional recommendations, only 22% of publicly insured youth with special health care needs and 16% of youth without special health care needs receive transition preparation services from their healthcare providers. We know that Medicaid agencies and managed care organizations have extensive experience addressing other types of transition, such as transition from inpatient to outpatient medical, behavioral, and long-term care settings. But we wanted to discover which, if any, states included pediatric to adult transition language in their Medicaid managed care contracts. So we did this by analyzing 37 standard and 7 specialty managed care contracts to see if any of them had specific pediatric to adult healthcare transition contract provisions. And we looked in these sections on definitions, member services and education, provider network, covered services, care coordination, and quality and evaluation. So our general finding was that few states did include this language. We found that in the general standard managed care contracts, 10 of the 37 states included language, but it tended to be pretty general without referring to specific transition services. And this language, we did find more of this language in the specialty managed care contracts. So 6 of the 7 contracts included transition language, and this language did tend to be more specific. And so later in this presentation, you'll get to hear from 2 of these states, which are Florida and Texas. So based on our findings, as well as recommendations from the 2018 clinical report on healthcare transition, evaluation studies, and our quality improvement experience at Got Transition, we developed at least 3 contract language options for each of those topics that I listed on the previous slide. And we summarize these options in this new report that is cited at the bottom of the slide. It also summarizes our findings from the analysis, as well as it includes specific examples of language that can be used or adapt to be included in managed care contracts. And now I'm going to walk through each of those sections and summarize the options that are included in that report. So the first was definitions, which are really important to include in contracts because they help to set the parameters of transition services throughout the rest of the contract. So the first option we developed was to include a standalone definition of pediatric to adult healthcare transition that could specify the transition age population of interest, as well as the transition goals. And if the contract already has a definition of transitional care, this could be expanded to explicitly mention pediatric to adult transition. And other definitions of services that encompass transitional care, such as continuity of care, could also be expanded to explicitly mention pediatric to adult healthcare transition. So the next section was member services and education. And it is important for youth and families to understand the changes that are going to take place when they turn age 18 and move to adult care. So the options that we developed to include in member services and education were first to include language about including information and education about pediatric to adult healthcare transition services and the managed care organization's approach to transition in member handbooks. The second was to include up-to-date information in provider directories about available adult providers for young adults with special healthcare needs. And the third was to help members who are experiencing barriers to care related to healthcare transition, such as difficulties with finding adult care providers and a lack of communication or exchange of updated medical information between providers. So it is also important to maintain a sufficient number and distribution of adult providers for youth and young adults with special healthcare needs, as well as to ensure the coordination and collaboration between pediatric and adult providers. So one of the options that we developed was to include language about conducting regular surveys of adult provider networks to assess the availability for special populations of transition-aged youth and young adults, and also to describe efforts to expand adult provider capacity. The second option was to include language about developing mechanisms to coordinate pediatric and adult providers and to ensure a safe and effective transition, including exchange of medical information. The third was to establish an organized process for transfer from pediatric to adult healthcare. This could include identification of adult providers, preparation and exchange of medical information, and offering pediatric consultation assistance as needed. So the next section we looked at was covered services, and we developed 4 options for including transition language in this section. So first, one option is to incorporate transition into early and periodic screening, diagnostic, and treatment, or EPSDT well visits, which could include conducting a transition readiness assessment and providing needed education for building self-care skills. The second was to incorporate transition into patient-centered medical home programs. This could be including requirements for an organized process in both pediatric and adult medical homes to facilitate transition. The third was to incorporate transition into behavioral health services. So this could encourage behavioral health providers to establish a planned process for transition, ensuring that adult behavioral health providers have processes in place to welcome and orient new young adults into their care. And the last one was to incorporate transition into health home services, which could be done by including pediatric to adult healthcare transition, specifically in the health home's definition of comprehensive transitional care. So next, for care coordination, these services are necessary to facilitate the continuity of care as youth and young adults change providers and systems of care. And in our analysis, this is the section where we found the most existing transition language in contracts. So the first option for including transition language was to explicitly mention pediatric to adult healthcare transition as part of care coordination programs. And this could also explicitly state the roles of the care coordinators in this process. The contract could also include provisions about conducting transition readiness and self-care skills assessments and providing needed education and counseling. Language could also incorporate transition planning into the member's comprehensive care plan, this care plan could include results from the transition readiness assessment, as well as the youth's transition goals, their medical summary, and emergency care plan. And the fourth was to state that transfer planning should be initiated 1 to 2 years prior to the date when the member is going to age out of the pediatric medical home, medical, behavioral, or other child serving systems of care. So these services could include assistance with identifying adult providers, helping them to identify other adult public programs that they might be eligible for, and creating a transfer package to share with the adult provider, which could include the latest transition readiness assessment, medical summary, and emergency care plan, and any needed legal documents. The last section was quality and evaluation. So quality improvement and evaluation activities can help to ensure the adoption of evidence-informed transition services. And the options we developed were first to measure the implementation of healthcare transition services. So this is something that could be done on an annual basis using one of GotTransition's customizable tools called the Current Assessment of Healthcare Transition, which assesses a practice's level of implementation of the 6 core elements. Another option is to measure outcomes of a structured transition approach at using selected outcomes aligning with the triple aim domains of population health, experience of care, and utilization or cost of care. And lastly, the language could be about conducting a pediatric to adult healthcare transition performance improvement project. And so you will actually hear an example of a state's performance improvement project just shortly. And this was in Florida's contract. So I will actually now go ahead and turn it to Johnny and Tanya to talk about their transition contract language.
Thank you so much, and greetings. We appreciate the opportunity to share some of our work on healthcare transition. Next slide, please. I wanted to first start off by highlighting our organizational structure here in Florida under the Department of Health so that you have a better understanding of some of our Title V leverage opportunities that we have for influencing our systems of care standards, including healthcare transition for our children with special healthcare needs population. Under the Office of CMS, also known, under the Office of Children's Medical Services, also known as CMS, we have our Specialty Programs Bureau, which includes our Title V Children with Special Healthcare Needs program and its subsequent priorities on patient-centered medical home and behavioral health, for which we include transition as a focus area. As part of our Specialty Programs Bureau, we have 27 contractual partnerships with 16 tertiary care systems around the state, which represents 7 condition-specific specialties, such as cleft lip, cleft palate, HIV, endocrine, etc. And together they come and form as a statewide network that's focused on access and quality. The other bureau under the Office of CMS includes the Specialty Managed Care Organization for Children with Serious and Chronic Special Healthcare Needs, otherwise known as the CMS plan. Next slide, please. Florida is one of the 5 most populated states with over 4 million children and about 20% or 800,000 having a special healthcare need. And of that, we have a subset of about 80,000 children that also have a medical complexity. While this only represents about 2% of all the children in Florida, like other states, we know that it dramatically impacts our health system resources, accounting for about 1/3 of all child health expenditures. As these children continue to grow into adulthood, the focus on healthcare transition is now more important than ever, as targeted efforts to better manage patients lead to better patient experiences, better outcomes, as well as substantial improvements in our health system's functioning and sustainability, all part of the quadruple aim in healthcare. Next slide, please. According to the National Survey of Children's Health Data for 2018 to 2019, about 1/3 of our children with special healthcare needs population, which was equivalent to about 300,000 children, are of the ages 12 to 17. As you can see, our progress between 2016 to 2018 had been slow. So we were very pleased with the recent survey data release and the 2.5-fold increase that we saw. However, still below the national average, we know that we have some work to do in this area. Next slide, please. In 2019, as a redesign to enhance the delivery system for our CMS managed care plan, we began a partnership with WellCare. And as a foundation, the standards for systems of care for children with special healthcare needs were incorporated into the contractual agreement, and this language was specific to healthcare transition. It is really important to emphasize that Title V funding is not used on the CMS health plan model. Rather, Title V is a partner at the table with the CMS health plan to inform and collaborate on system of care infrastructure and support type activities and initiatives. Our work on transition-related activities is a really good example of this collaborative partnership in action. And I'm going to transition you to Tanya Hillary, our Vice President of Operations for the CMS Health Plan, to hear more about this.
Great, thank you, Johnny. So good afternoon, and first of all, thank you very much for inviting me to participate in today's session. It's a real honor to be here representing Children's Medical Services Health Plan and the Florida Department of Health, and to share with you the evidence-driven quality improvement approach that we adopted in our program design. Yeah, as we talked about at the beginning, when Annie was going through the ways in which transition can be incorporated into a contract, we heard a lot of different opportunities, right, for how that might work. With the CMS health plan contract specifically, the department was clear in what their objective was in wanting us to have a transition program, but they were not prescriptive in that design. And so it allowed us a lot of latitude in terms of how to go about designing and implementing a program that would meet the needs of the children and youth in our program. So as we were moving through implementation, we adopted the GOT transition framework really as the cornerstone of our program. And you'll see that represented as we talk through some of those elements. And that really has allowed us to use GOT as the framework, if you will, for what our program entailed. So I'm going to talk a little bit about what those components are and how they work for our program. But before we do that, I just would be remiss if I didn't acknowledge that collaboration that Johnny mentioned. You know, we're very fortunate to be able to put together a multidisciplinary team of health plan staff that included quality management, our care management, quality improvement, data analytics, and provider relations staff, who really helped design, right, the way we were going to execute this. And then we had that incredible partnership with the Department of Health, including the Title V program, as well as family caregivers. So the things that I'm going to talk about next really reflect that collaborative output. Next slide. So one of the things to know as we talk about our transition aged youth program is a little bit about how even our care management program works. And so Johnny talked a little bit about, the members or the children in Florida who have serious and chronic conditions. Those individuals who enroll in our plan are all assigned to a primary nurse or behavioral health care manager. And that care manager provides both in-person as well as telephonic care coordination to all of our enrollees and their families, but they're also central to the execution of our transition aged youth program. And that's important, again, because as we talk about some of the elements, the 6 core elements, you'll see how the care manager plays that pivotal role. So Annie mentioned the importance of having a healthcare transition policy. We've adopted one within CMS Health Plan. That policy does outline the expectations for our program. And unlike a lot of other policies that may be more internally focused on the organization, this is shared not only with our care management staff, but it is also made available to our members and their families through our member enrollment collateral. The other thing that is a core element, of course, is the electronic registry. We do have an electronic registry that we use to identify and track members as they complete their healthcare transition activities. This registry is integrated within our care management system, really providing that care manager at the center of the wheel, if you will, a holistic view of all the coordination support that's needed, both related to transition and not. Included in that is an assessment. So our care managers are responsible for assessing all new enrollees and then continuing to do assessments on a periodic basis. Beginning at 14, that assessment includes a transition readiness assessment. And our plan adopted the TRASP score to do that, and we've modified it specifically to meet the needs of the enrollees that we serve, as well as some of the contract requirements that we have with the department. It's a 26-question branching survey, depending on a child or youth specific situations. And that is also incorporated or integrated into our care management system. And the reason that's so important is because it's then linked into the care planning software that we're utilizing. So as needs are identified through that healthcare transition needs assessment, our care managers are able to then work with the families to develop member and family-centered goals, and then to identify those actions that are needed in order to effectuate those goals and achieve those needs. And then that plan of care, of course, is shared with families. It's also provided to our providers, their PCPs, and also reviewed and updated on a regular basis and as needed. The transfer of care process is obviously, central to all of this. And so because every child has a care manager, those care managers really can help assist in the connecting of individuals to potential adult program providers, and including coordinating, if needed, transportation services, scheduling appointments, educating families about what to expect for the initial appointments and that type of thing. And then the last element, of course, is around measuring success. That's a critical part of any quality improvement focused program. And so as Johnny mentioned, we do have a performance improvement plan that is tied to our transition age youth program. And so if you'll go to the next slide, I'll speak briefly to that. So our PIP is, again, it's focused on healthcare transition. The department didn't prescribe in the contract what it needed to do or include, just that we needed to have one that was focused on this topic specifically. So we are focused on what percentage of members between 18 and 21 years of age are we able to, through the 6 elements that I just spoke of, help to successfully transition from a pediatric serving provider to an adult care provider. This past year, as our first year operating the plan on behalf of the department, was our baseline year. And so no surprise, we've identified, a lack of program tools and a lack of program design as some of the barriers. So we implemented the program that I've just talked about. And then we also understand, right, that many times there's some reluctance on the part of the members or the parents or guardians in making those changes. So we're looking at how we can address that again through education and support. I've already talked about the multidisciplinary work group, and then the interventions, of course, are those 6 pieces that I spoke of. So that's a little bit about our program, the CMS Health Plan Transition Age Youth Program. I'm going to turn it back over to Johnny to talk a little bit about some of the challenges and opportunities as we move forward.
Thanks, Tanya. It's been exciting what we've been able to accomplish a short time together. So we look forward to continuing to build upon this in the future. And first, when we're talking about challenges and possible solutions, we do want to acknowledge that these challenges existed before COVID, and then absolutely as a result of COVID, they continue to be challenges. And so one of the white elephants in the room that we like to call it, if you will, as our challenges can be that it is difficult to find adult providers that are equipped to accept our youth with special health needs population, especially those with medical complexities. So again, very fortunate that we have our Title V partnership that we do with the CMS Health Plan. We are, in addition with Got Transition, exploring the potential of implementing a small pilot that looks at those value-based payment options that could be considered, and of course, considering to use our Got Transitions framework as part of that. As I mentioned at the beginning of the presentation, with our specialty program contracts with our tertiary system partners, we've been able to join these individual institutions with other condition-like counterparts in their state to really focus on a network, if you will, a statewide network that's focused on learning and action with that quality improvement concentration. As part of these efforts, many of them themselves identified healthcare transition activities that they would like to work on in collaboration for the upcoming year. So we're really looking forward to learning from these efforts as part of those small tests of change and next steps. In addition, as part of the work that we do with our Title V action plan and that strategic planning, we're going to be conducting focus groups with adult providers to discuss those barriers and solutions and accepting more of those young patients with special healthcare needs into their practice. We will also be identifying adult providers who are willing to build on their healthcare transition skills, again, using our Got Transitions framework and doing this and then measuring their progress over time. We're also fortunate enough to be collaborating with the other Big 5 populous states, such as Texas and their Children with Special Healthcare Needs program, to work on identifying other evidence-based or informed strategies to really help us increase the numbers of adult providers that we have and the knowledge and capacity to care for our young adults with special healthcare needs. Tanya, I'm going to hand it over to you to talk a little bit more about the challenge with the medical record or information transfer.
Great, thanks, Johnny. So one of the things that I'm thrilled about with the idea of doing physician focus groups is understanding to what degree the systems or the lack of systems, and I'm not talking about like necessarily just purely information technology, but the broader system either helps or hinders this healthcare transition. One of the things that we hear often from our providers serving children and youth with special healthcare needs in CMS Health Plan is that when they have this significant medical complexity, the amount of time and effort that requires an effective transition from one physician to another or one provider to another, when there's often multiple providers serving these kids and families, is not insignificant. And so I would venture to say that some of the systems challenges or barriers are related to, again, that financial compensation for doing so, and having then the information technology that maybe helps to facilitate that in a more seamless way. So I'm really excited to hear the results of the Title V focus groups and seeing what we can do then in terms of technology and big system changes that we can make as part of CMS Health Plan.
Okay, thank you. So now I'll go ahead and turn it over to Elizabeth to talk about your contract language in Texas.
Yes. Thank you. I was also pleased to see on the participant list that we've got 2 transition specialists from Texas who have been very instrumental in making sure that things are running smoothly. So a shout out to Myra Phelps and Toya Creel, who are on this call today, and I've been on multiple conversations with them over the course of the last couple of weeks. Texas is a very large state, 29 million people in Texas, and we have a large number of children. In 2013, our Texas legislature decided to create legislation that required the last remaining group of children who received Medicaid services in a Medicaid fee-for-service structure, required them to go into Medicaid managed care. We had already had Medicaid managed care for children who were eligible for Medicaid due to poverty, and we had Medicaid managed care for children in our foster care system through 2 different managed care products. But this was an attempt by the legislature to put all children who have SSI, meaning they've got a qualifying disability through Social Security Administration, and all children who are on home and community-based waivers, including our medically dependent children's program, which are our children who are dependent on technology for the most part, like ventilators, to breathe, into Medicaid managed care. And so that bill passed in 2013. And at that point, the bill also called for the state or Health and Human Services Commission to really tap into expertise of people on the Children's Policy Council, and also to create a Star Kids Advisory Committee. And so our Children's Policy Council has been around since 2001, and it is an advisory council to our Health and Human Services Commission, comprised of mainly family members of children with special health care needs, family members of children who have a behavioral health care need, family members of children with a physical support need, and then also some advocacy groups and some physicians. And so that group really, I think it was really important that we called out that group for helping in developing some of the recommendations in the Star Kids Managed Care Project, as well as a Star Kids Advisory Committee that's been going on since 2013, that's comprised of providers, physicians, managed care organizations, advocates. So both of these 2 groups have really been instrumental in informing the state on what needs to happen to best support children in a Medicaid managed care environment. So in 2016, November of 2016, about 160,000 children rolled in, and young adults 0 to 21 rolled into Medicaid managed care. It was not a smooth transition. There were lots of bumps along the road, and we still continue to work through some of those on a regular basis. And we hear about them constantly through our Star Kids Medicaid Managed Care Advisory Committee. So next slide. The Children's Policy Council was really ready and poised to jump on this when it first came out in 2013. And so the Policy Council got together and developed a number of recommendations that were going to be essential to really best supporting children and STAR Kids. HHSC, I think our Health and Human Services Commission was really proactive. They wanted to hear what community groups thought. They wanted input on what the request for proposal was going to look like. They wanted input into what those key contract elements were going to be to best support children with complex healthcare needs and complex long-term support needs. And so that group got together, and I've provided a link here for the recommendations. But that group got together and provided a number of recommendations, including care coordination, and the care coordination that had to include transition from pediatric care to adult health care. We borrowed very heavily from GOT transition and have been big advocates for making sure that healthcare transition from pediatric care to adult care is a good transition. We also made recommendations about individual service plans, that each child would have an individual service plan that was person-centered and driven by the family and the goals of the family. And we included some pretty strong recommendations about transition, the healthcare transition from pediatric care to adult care, as well as we also made recommendations about networks, including adult providers in the network. The STAR Kids Advisory Committee also was going on. It started in 2013, and we met on a quarterly basis and continue to meet on a quarterly basis to provide ongoing feedback to the state on what improvements could be made to STAR Kids. At the very beginning, we made lots of recommendations about the key contract elements, including, again, care coordination, service plans, network adequacy, assessments, and transition from pediatric care to adult care. I provided a link to our most recent advisory committee report that was in January 2020. We are working on our report that's going to be due soon, and I'm really excited about this conversation because I'm going to take some of the things from the recommendations that you all have made through GOT transition, and I really love some of the Florida pieces, and improve our managed care product through our next iteration of our report. Next slide. So with Texas Medicaid managed care, we were able to really get key, I think, provisions into our contract. And I really feel it's critical that we have language in the contract that is really strong and that really promotes transition and promotes best practices for children and youth. We have 9 managed care organizations that are providers under STAR Kids. And we have, our state is broken into service delivery areas. And I believe I don't remember how many service delivery areas. We have, I think, 13. And we have at least 2 managed care plans in each service delivery area. So having some consistent contract language is critical. And so we were able to get into the contract language that requires transition planning to start for children beginning at age 15. And it's dispersed throughout the contract, but we have in our STAR Kids program, we have an annual comprehensive assessment that is done for each child. It's called a STAR Kids Screening and Assessment Instrument. It's a very long face-to-face assessment that's done with each child each year. And the result of that STAR Kids screening and assessment instrument is then found in an individual service plan. And that individual service plan has to include transition elements for anybody who is 15 or above. There is also service coordination. Each child has a service coordinator with STAR Kids, and those service coordinators have a service coordination team that includes a transition specialist. And I think that this was one of the key elements that we were able to get in our managed care contract is that each Medicaid managed care entity had to have transition specialists that could then provide best practice consultation and work directly with teams, service coordination teams, but could also work with children in developing a transition plan. There's also language in the Texas contract that requires that the state not only have pediatricians as primary care physicians, but they have to have primary care physicians to serve young adults. And so, and they're very clear that says a pediatrician is not necessarily an appropriate provider for someone over the age of 18 years of age. And so that was, I think, something that we continue to really work on, but there is contract language to that effect. And I've given you a link to the current contract. Next slide. We also in Texas, and I'm assuming many states have this, we've got language that's in contract, but we also have a handbook. And there's a lot of information in handbooks that sometimes goes a little bit deeper than what's in contract, but we do have a Texas Medicaid managed care handbook. It's a Star Kids handbook that all of the managed care entities use, the ones that are delivering services under Star Kids. There is an appendix that is part of that handbook that speaks specifically to transition services and the transition services that need to happen at different points in time, at different ages. I think it was a really great first attempt by our state to develop some handbook languages looking at kind of the phases of transition and what needs to happen for somebody who's between 15 and 16, what needs to happen when somebody approaches 17, 18, what needs to happen when they get a little bit older. I think a group of us, including our subcommittee, our Star Kids Advisory Committee subcommittee on transition, which includes some of our subject matter experts like those key transition specialists within managed care organizations. I think we're taking a look at that to see how we can improve that handbook language. But there's definitely language about making sure that an individual has knowledge of his or her own current and future healthcare needs, health and wellness education to assist the individual with managing their own healthcare needs and how to make their own medical appointments, how to keep their medical appointments, how to order supplies, how to kind of make sure that they're in control of their healthcare, as well as assisting the individual, the young adult, to find a primary care provider, specialists as needed, dentists. And then there's a whole section on assisting the young person in transitioning from the Star Kids Medicaid managed care product to the adult product, Star Plus, that is for people who are 21 or over. And so I've given also a link to that handbook. Next slide. Some of our big issues that we are working on right now and will continue to work on are right now, we've got great language, I think, in contract. We've got good language in the handbook, but there's really no standardization and there's no standardized process and tools that can be used by the managed care organizations to ensure quality healthcare transition. And I know that some of the managed care transition specialists will speak to this. There's a vast difference between quality from one managed care entity to another. And so I think that there is a lot of opportunity to improve kind of the process of transition by looking at some of those standardized processes and tools to be used among all the managed care organizations in Texas. There's also a real need for some ongoing training of the managed care organizations. Again, 9 managed care organizations serving 160,000 children. And I think that the transition specialists are starving for knowledge and want to make sure that what they're doing is compliant with best practices and moving in that direction of quality. And so I think that we're making some recommendations. We've got an incredible Title V CSHCN group that's working on healthcare transitions, as well as some of our parent education groups. And so I think we're trying to figure out ways that we can strengthen the access to best practices an open dialogue among those transition specialists so that as they work with children and youth and families, they can kind of share stories and best practices among each other. The other big issue is some improved coordination and communication between the pediatric and adult managed care organizations. In Texas, we go from Star Kids, and at 21, they go into the Star Plus product. And there's been issues about really ensuring good coordination and communication. And HIPAA often gets used as the reason why once a referral has been made to an adult managed care organization and they become members of that organization, then they can't then communicate with the managed care organization that had the transition specialist that was working on the youth's transition. So we are working with some strategies to try to figure out how best to improve that communication among the sending managed care organization and the receiving managed care organization, because they are often they're different Medicaid managed care organizations. We have been really looking at, I think, taking advantage of some of the work that Got Transitions has done on the value-based payment options for transition and seeing what we can do to enhance transition payments and making sure that we have the ability to have both a coordinated effort between a pediatric provider and also for adult providers. So it's that consultation support to adult clinicians. This has been one of the big areas that pediatricians who are supporting some of the more medically complex children are very concerned that we don't have a smooth transition from the pediatric provider to the adult provider. And we need to do some ways to enhance that, including looking at concurrent payments for the pediatric provider and the adult provider. There's some opportunity, I think, real opportunity. With COVID, we've learned quite a bit about the use of telehealth, and with Star Kids, we've definitely learned about telehealth and the importance of that for children who have significant medical complexities. We are able to now have groups, health homes, that are having pediatric 6-month consultative visits. So you have you have the health home PCP on the call, the pediatrician. You've got all of the different specialists, so the neurologists, the gastroenterologists that are on those calls, pulmonologists. You've got the home health agencies that are providing private duty nursing on the call. You've got the durable medical equipment companies, and the families that are there with their child. And so it's been a really incredible way for us to really figure out how to bring that team together and to do really improved coordination and planning. And I think that model would be a perfect model for transition, because if you had the pediatrician and the youth and family and the adult practitioner on a telehealth call together, I think that we could develop some really good planning for that smooth transition. And we're looking at parity of payment for telehealth. We've also are continuing to look at expanded network of adult providers. Adult providers are very reluctant to join in on the Star Kids product because people are only on it for a short period of time between 18 and 21, and then they go on to the adult system. And so it has been a real issue trying to make sure that we have an adequate network of adult providers, especially in rural areas. And so I think that one's been something that we're going to continue to work on. And I think at this point, there's a lot of work ahead, but I think that there's some real opportunities, and I'm excited to take some of the work of this group and look at refreshing our recommendations and including some of the recommendations that you all have made on improving contract provisions. So thank you.
All right. Thank you very much. So just quickly in conclusion, we think state Medicaid agencies and their managed care organizations are in a unique position to expand the availability of transitional care. And you've heard today, Florida and Texas offer some exciting examples of innovation and best practices as a way forward. And we encourage you to check out our new report, which has these options that I went over, and it also has some ready-made suggestions for specific language that can be used or adapted. And so I think we have a few questions that have come through in the chat.
The first question is going to be for Elizabeth. Could you talk a little bit about the contextual factors that help the Children's Policy Council be open to / enthusiastic about pediatric to adult healthcare transition? Why were they enthusiastic about that, and what motivated them to include the recommendation versus some other competing topic?
The Policy Council for Children, it's now called Policy Council for Children and Families, is a council primarily made up of families of children and youth between the ages of birth to 26. And so we were able to get that increased to 26. And healthcare transition is a big concern for families. And so we always look at a number of different things that we need to focus on issues. So long-term services and supports in the home always rise to the top. But healthcare transition, I can guarantee, has been on the topic of conversation for every single one of those reports. And so it's not been a heavy lift to get them to really focus on it. It's important.
I think I'm being very sensitive about the time now. We're close to 3 o'clock. And I want to make certain that everybody knows that the questions that have come into the chat, we're going to be coordinating a response to you on that. I also want to just reflect that the examples that we've shown you today are specialty Medicaid managed care plans. And you heard Annie say in our analysis that those were the plans that have done more. But certainly we hope that these examples will carry forward to general managed care plans. You also heard this, I think, really exciting partnerships that have been forming between Medicaid agencies, Title V agencies, managed care organizations, and family groups. This is really new territory and an opportunity for us all to build it together. And these examples that you've heard today, I think is important to understand. The state has given a lot of authority of doing this work to the care plans. There's many ways that this can be structured, but we haven't had the time to talk about really how the care plan is conveying this to the providers. And you know, I think that there's lots of levels to this, but it's very impressive, I think, that the authority, the responsibility for this work has been conveyed from the state agency to a care plan. And, you know, that's a big deal. And it will make, as I think Elizabeth said, there's going to be more consistency in how this is done going forward. And so I thank all of you, especially our panelists today, for this very special presentation. And we will be back in touch with those of you who have sent questions to make certain we've got your responses. This will also be available on our website, gottransition.org, both the report and the slides and webinar.